Okay, thank you everyone for attending the kickoff webinar for the Autumn 2020 Davis E-Lecture Series. The Center for Health Administration Studies has always advocated for innovative and evolving technologies and methodologies to disseminate and champion health services, research, and policy analysis. With many crises impacting the United States and the globe in 2020, CHAS has a goal to make the latest in health research and services policy accessible to as many people as possible. In a moment, I'll pass the mic to Professor Harold Pollack to offer brief opening remarks and to provide an introduction of today's presenter, SSA Professor and CHAS Co-Director, SSA Professor and CHAS Co-Director Colleen Grogan. To keep continuity today and allow the presenter to focus on the presentation, we'll be fielding questions at the end of the slideshow. Please feel free to add your questions to the Q&A pane so that we can sort through them and answer them in their entirety. We'll do the best to answer our questions at the end. A copy of today's PowerPoint slides will be available on the CHAS website at chas.uchicago.edu. And a recording of this webinar will be available on the CHAS website in the future, as well as on our CHAS YouTube channel. I now hand the mic over to Harold Pollack. Thank you.
Thank you, Keith. And thanks everybody for joining. I actually quickly perused the participant list and I see that Colleen's mom is not on the list. So I'm going to give a short introduction to Colleen, since just about everybody on here knows Colleen well for all the years that Colleen has been, has been active in the Davis Seminar. Colleen's one of the nation's top scholars at the intersection of political science and public health. Edited the Journal of Health Politics, Policy, and Law, was president of the Health Politics and Policy section of the American Political Science Association, has done distinguished work on Medicaid, and most recently, particularly concerning the opioid epidemic. Colleen's going to talk today about COVID, and I just can't wait to hear what you have to say, Colleen. So take it away.
Okay, great. Hopefully everybody can hear me okay. Thumbs up. I can only see Harold. Can you give me the thumbs up? Thank you. Okay, I can push this. All right, so yes, today I'm going to talk about COVID, but specifically about the COVID, in the title of the talk I said bailout funds, but more specifically the provider relief funds. Before I begin, I just want to acknowledge my collaborator in this project, Michael Gasmano from Rutgers University, and research assistantship help from Juliana Lieber, who's a second-year master's student at SSA, and funding from SSA University of Chicago to support Juliana's work over the summer during COVID. So I think it's become quite obvious now to, I'm sure, all of you participating in this talk today that COVID exposed huge inequalities in the American society, most significantly when COVID cases and the rates of COVID deaths started to emerge, data started to emerge. It was really quite striking. And I'm sure many of you, if you haven't seen this particular graph, you've seen tables or graphs like this that just really illustrate the dramatic differences in hospitalization rates for COVID, and similarly the COVID death rates by race, really quite striking. And the reasons for this are numerous, and I'm sure you've heard many of these reasons as well over the last many months, that they have to do with health disparities that were there long before the pandemic, and of course labor force participation differences by race and by income that creates unequal exposure to COVID. And so this quote by David Williams, who's a professor at Harvard, has actually almost become a cliche at this point. I think we've all probably heard it quite a bit. With COVID-19, we are all in the same storm, but we are not all in the same boat. So what was the response to some of these dramatic inequities and just the dramatic economic downturn in the US? Of course, we all also know that the CARES Act was the kind of first major response from the federal government. It was signed on March 27th, 2020, over $2 trillion to, quote, protect the American people from the public health and economic impacts of COVID-19. And so, of course, part of that, the majority of the CARES Act funding was to deal with the economic impact. And of course, the rates of unemployment, you see here also the racial disparities of unemployment. Again, this isn't unique to COVID. We saw similar disparities in how the 2008 economic recession impacted American laborers by race, but still quite dramatic. And I should say, I mean, that money that goes to economic and to food insecurity, those many concerns clearly are very, very important to dealing with the health disparities that are apparent for COVID. Many of us have been talking for a long time about how the differences in health and what impacts health more than or certainly just as much, but probably more than health are the social determinants of health, right? And so we can look at those of the CARES Act as having, even when it's going to housing and food, employment, as having an important impact on health. Having said all that, what I want to do today is think about how the healthcare system responded and then how the federal government responded to the healthcare system, focus on that aspect of it. And just the punchline was kind of already given away in the title of my talk, which is that we had an unequal system, which unfortunately becomes more unequal given our response. So I want to back up here a little bit and just talk about COVID and the hospital industry. So again, I've been saying the healthcare system, but really for this talk, I'm focusing in on the hospital industry. Since March, the industry claimed financial losses of about $55 billion per month. There were operating revenue decreases around 40 to 45% for the average hospital. And the reason for that, I think, is probably clear to most of you, but I'll just say it to make sure we're all on the same page, that hospitals were experiencing major losses because emergency room admissions are not nearly as profitable as payments for elective procedures, which were eliminated during the first several months of the pandemic. And not only are the payments for the differences that occurred during COVID lower, but the average COVID patients also hospitals received lower payments. And that's because there was a higher proportion of COVID patients that were on Medicaid or uninsured. And I want to highlight here the average because whenever you're talking particularly about the hospital industry, the word average is actually kind of problematic because we really have a very bifurcated hospital system. And so the average, there's a huge standard deviation there, a huge distribution on the tails that averages belie. So now I want to shift and think a little bit about the bifurcated healthcare system, or really hospital system, and then return to kind of thinking about the federal response. And just want to use a kind of a little story about Chicago to think about how kind of some of the early responses to this bifurcated hospital system. And some of you might remember back in the beginning of April that Mayor Lori Lightfoot, when the Chicago Public Health Department had just released data showing that while Black residents make up 30% of Chicago's population, they accounted for 52% of COVID cases and 72% of Chicago COVID deaths. And she said, quote, "Those numbers take your breath away. It's unacceptable. No one should think this is okay." And Mayor Lightfoot wasn't alone. Mayors and governors across the country expressed concerns, similar concerns, when dramatic racial differences this was showing to be the case. The numbers were similar in pretty much every major city in the US. And most mayors and governors mentioned the racial inequalities and health disparities prior to the pandemic as sort of the major reason for these extreme racial differences. Interestingly, they acknowledged much less often the systemic differences within the healthcare system itself, and very few mentioned the system's unequal response to COVID. I know this writing is quite small, but I want to kind of take the time to just read this exchange that occurred on the show Chicago Tonight, which is on public television. Some of you might have seen it. I thought the exchange was really a very good example of some of the assumptions that people might have about our hospital system. So I wanted to highlight it. Carol Murrin, who's the reporter for Chicago Tonight, asked the healthcare administrator, Sean O'Grady from North Shore University Health System, the following question. Mr. O'Grady, safety net hospitals on the west and south sides of Chicago are in more serious need of equipment versus more affluent hospitals, not unlike North Shore, his hospital that he works for. Is there a sharing at all going on between the more affluent with the less affluent? And Mr. O'Grady responded, "Well, Carol, as you know, Swedish Provident Hospital joined North Shore earlier this year, and we have been working very closely with them as a safety net hospital. That's a part of our system to ensure that they have the appropriate supplies and equipment that they need, and that they are taken care of just as we are taking care of our folks in the legacy North Shore system." Then Carol asks, "But hospitals in a classic sense compete against each other. But in this plague, it's a different sort of story. So what is the kind of sharing that might be happening, or is it not?" And Mr. O'Grady responded, "So I talk to my colleagues around the city on a regular basis to find out what they're doing in various domains of the response plans. And we are regularly talking about how we can help one another. I think the governor and the Department of Public Health have done an excellent job in bringing the provider community together. And I think through those vehicles, we are collaborating, sharing, and passing information. And to whatever extent we can, I know my colleagues and I are very committed to sharing across the market." So I think there's a couple things in that exchange that I want to highlight. First, it really kind of highlights how normalized our hospital inequalities have become, that we talk about the more affluent and less affluent hospitals and just common discourse without a problem. That's just sort of assumed that that's a part of our system. I also think what's really important to focus, to highlight in this exchange is Carol Morin's, the reporter's question, just going back to this page, which I've highlighted. Her second question, hospitals in a classic sense compete against one another, but it sort of must be different during this pandemic, right? And one might think that it would be different, but really there is no government planning for how affluent hospitals should share with non-affluent hospitals when an emergency or a pandemic occurs. We might think that that is in place because it does seem logical, as this reporter thought, but it really isn't in place in the US. And I think, again, I want to highlight that because it seems very logical. It seems we would have it in place. And when you look at other countries, in fact, they do have systems like that in place. There is government planning and government response mechanisms in place. We really rely, as she said, on competition in the healthcare marketplace for hospitals to respond. And that's really important when you think about then how do they respond during a pandemic. So sharing and collaboration, not voluntarily, not on their own, and government really didn't require it. So here's an example of really what was the response. On the same day that the Public Health Department announced the high rates of COVID among Black and Brown Chicagoans, Stroger Health System announced that it would temporarily close Provident Hospital's emergency room. And again, many of you who are on the call today know Provident is just next door to University of Chicago in Washington Park. It's located and takes care of predominantly Black patients on the south side of Chicago, located in a neighborhood with high rates of poverty. Their patients are predominantly Black and poor. And the president of the Chicago Medical Society said, quote, "In the safety net hospitals, those hospitals with a lower degree of resources in more fiscally challenged areas, they are having more trouble and need more support, whereas some larger, more affluent health networks are well-resourced and were able to prepare for this in a more timely fashion." So, we get the acknowledgement from the president of the Chicago Medical Societies explicitly saying there are affluent hospitals that are more prepared and safety net hospitals that really are not prepared for this pandemic. We know that voluntary sharing between the two are not happening. And so part of the hospital industry response is to the response of the market, which is hospital closures. 42 hospitals closed or filed for bankruptcy between January 1 and June 2020. Many of those were rural hospitals. And that's been a continual increase in hospital closures for the past decade. But also a large number of furloughs occurring in the healthcare industry that, again, I'm sure many of you read about and heard about. So 42,000 healthcare workers lost their jobs in March and another 1.4 million in April, of which 135,000 were from hospitals specifically. The healthcare industry is such a major part of the U.S. economy that it's not surprising that this contributed quite significantly to the unemployment rate. So the federal government did respond. It passed the Provider Relief Fund under the CARES Act, and the purpose, and this is a quote from the legislation, is designed to provide an influx of money to hospitals and other healthcare entities to help them respond to the pandemic. Congress also said in its signing of the bill, quote, "The fund could be used to offset costs related to treating COVID patients or to reimburse for lost revenue." So there were four main hospital distributions in the provider relief funds. The first was called a general distribution, the second high impact distribution, the third a distribution to rural hospitals, and fourth a distribution to safety net hospitals. And then I have some of the other ones written down there to nursing facilities, the Indian Health Service, and Medicaid and CHIP providers, but I'm going to focus on those four main distributions that included hospitals. Now, each of these distributions, they didn't occur all at once, they were staggered over time. And so the first distribution was the general distribution. And in the beginning of April, there was initial an initial $30 billion in grants that was distributed to eligible hospitals, but also lots of other providers as well, not just hospitals. And then later in the month, an additional $20 billion was allocated to many more, about 15,000 providers. And what's really important about this general distribution is it was based on the share of net patient revenue. So I'm going to go back to that in a bit, but let me just tell you about the other distributions. The second is the rural distribution, and that occurred on May 6th. Health and Human Services allocated $10 billion to rural acute general hospitals, rural health clinics, critical access hospitals. Again, kind of not only hospitals, but other healthcare providers in rural areas. The third distribution occurred on May 7th. It was hotspot payments, are also called the high impact payment, because it provided $12 billion in funding to hospitals that had that were experiencing a higher influx of COVID patients. So to be eligible, a hospital had to have at least 100 COVID-19 admissions to be eligible for this distribution. So I think the way to view this distribution is that it was really focused on COVID need. And then finally, there was a fourth distribution to safety net hospitals on June 9th for $10 billion, a little over $10 billion in relief funding to hospitals that provide a large number of Medicaid of services to Medicaid beneficiaries and uninsured patients. So just based on the timeline and the funding amounts, one might argue that Health and Human Services, when they were charged with setting up what the distribution formulas would look like and when it would be allocated, that they prioritized revenues lost over COVID need. And the reason I'm saying that is based on the general distribution was based on kind of revenues lost or net. The higher net revenues you have, the higher the distribution, as opposed to COVID need. And so this quickly raised questions of fairness. Was that distribution to hospitals across the country, was that a fair distribution? And many newspapers and journals in healthcare policy journals and industry reported findings similar to this, which is that 20 hospital corporations, or the large health systems, received $5 billion in government provider relief funding payments, and at the same time that they received these payments, they were holding more than $100 billion in reserves. This is a very busy slide, but I'm going to just highlight for you what's important about it. The Becker Hospital Review publication had a series of different articles on the hospitals that were actually still doing very well despite the pandemic. And so these are 6 hospitals that reported very solid financial positions in terms of credit ratings. So you'll see sort of AAA or AA credit ratings. And of those hospitals, you can see that many of them were receiving pretty high provider relief funding payments. And then in contrast, you also had a number of hospitals that were reporting credit rating downgrades. So from BB to BB minus, as you can see. And so I've highlighted 4 here that all had credit rating downgrades. And just as an illustration of some of the concerns that were raised, these these hospitals as part of health systems received no funding from the provider relief funds. So you also had the Kaiser Family Foundation did an analysis based on the formula of the first allocation. So just looking at if you if you simulate what hospitals should have gotten based on Health and Human Services formula for the general distribution, which was based on revenue of patient revenues, they were able to show the following graph, which is that hospitals with the highest share of private insurance revenue were on average getting higher payments per bed than hospitals with the lower share of private insurance revenue. Because this, you can see this, this characteristic of hospitals that Kaiser is getting at is really another proxy for the safety net. So as I think I mentioned before, the safety net is characterized as hospitals, if you're part of the hospital safety net, you often have a fairly high proportion of your patients are Medicaid, insured by Medicaid or uninsured. And so you're going to have a low share of private insurance revenue. So basically what they're sort of illustrating, another way to look at this graph is the safety net is getting a lower average payment in relief funding. So that brings me to the work that we did specifically to look at the provider relief funding. And what we were interested in is Kaiser simulated what hospitals should have gotten based on the formula, but Health and Human Services, actually HRSA, has released the data for the actual payments to individual hospitals. They released the data for the first general distribution. It actually lists for all providers, and they released the data for the hotspot distribution or high impact distribution, which lists exactly what each hospital got. Unfortunately, for the third and fourth distributions to rural hospitals and the safety net, they only list the totals for each state. So we don't have the data for the individual hospitals, but we're in the process of trying to simulate that. Unfortunately, I don't have that ready for you today. So today, we're just going to be looking at the first and second distributions. And then also, because the first distribution, none of these have an ID to connect the data to the RAN hospital database that gives us hospital characteristics. So we had to really, this is what Juliana Lieber did for us all summer, was the very tedious but really important work of putting in the hospital ID so that we could merge these data and understand better kind of which hospitals were getting how much in terms of funding. And because that's such tedious work, we're unfortunately still at it, but we have completed it for New York, which I think is an important state to begin with, because of course New York State was at the epicenter of the pandemic in the very early months of the pandemic when these distributions were being released. So it gives us a good picture of how the federal government was responding to the pandemic in terms of funding to hospitals. So what happened in New York? As I said, we are able to look at the first distribution and the second distribution, and then we total that up to look at total payments. And then we merge that with the RAN hospital data. And for today, we look at two main characteristics. One is days of cash on hand, because that's a very good measure of a hospital's financial health. There are other measures we could have used, but I think this one is from reading different financial articles on hospital finances, that this is considered kind of one of the best measures of financial health. And then secondly, we look at whether the hospital is a DISH provider. And that means they provide a disproportionately high share to Medicare and Medicaid patients. Now, ideally, we would just be looking at Medicaid here to really replicate more the safety net. And unfortunately, we don't have, we will be getting that variable, but we don't have that yet. So this one is a DISH that includes Medicare and Medicaid. So here's just the first graph, and you'll see that it looks similar to the graph you saw that Kaiser reported on their simulation of the formula for the first distribution. So here you just see that for hospitals that have less than 50 days of cash on hand, they're getting significantly less in average payments per bed. So we look at payments per bed to adjust for the difference in size across hospitals. And then if you look at relief payments by DISH status, whether the hospital is a DISH provider, disproportionate share. Similarly, you see that if you're a DISH provider, you're getting on average less in terms of provider relief payments per bed than if you're not. Now, if we look at the second distribution, the high impact payments per bed, it is, I think, very illustrative of the fact that some of the quotes that I mentioned before in the situation in Chicago, that the safety net hospitals are very much on the front lines of taking care of COVID patients. And you can see that when you distribute relief funding according to COVID patients, so you might say COVID need, that those hospitals that are suffering more financially, they have less than 50 days of cash on hand, they received a much higher average hotspot payment per bed than hospitals that are doing better financially. And similarly, you can that kind of comes out as well when you look at it as DISH providers. So DISH providers are receiving a lot more in the hotspot payments than non-DISH providers. And then finally, when we put the two together, that was sort of our test of, is it a wash in the end? Did the second distribution bring the safety net and the more financially weak hospitals up to the same levels as the hospitals that are more financially well off? And unfortunately, it didn't. So when we added the first distribution, the second distribution together, the hospitals that are less well off, the kind of safety net hospitals here, are received on average significantly less. Now, I'm not showing you any statistics here in terms of this is statistically significant because this isn't a sample. This is looking at all the hospitals in New York and looking at the actual payment distributions. So we kind of have a census for New York, and I'm not trying to make claims about other states. So I said after, some of the conclusions early on, when people just looked at how the timing of the distributions and the formula of the distributions, many concluded that Health and Human Services prioritize revenue lost over COVID need. But I think our findings revise that conclusion a little bit in the following way, that when we look at the timeline and really the actual distribution of funding to hospitals, at least in New York, again, not nationwide, but in the New York case, what we find is that they prioritize the more affluent hospitals over the less affluent hospitals. So to use that language again, and if we want to be more explicit about what that language means, I think we would conclude that wealthy hospitals that predominantly take care of private insurance patients were prioritized over safety net hospitals that predominantly take care of the uninsured and public insurance patients. And because there's such a strong overlap in terms of the type of insurance that people have in the US and race, that is that people, Black and brown folks, are much more likely to have Medicaid or to be uninsured. It is also then the implication is that hospitals that take care of a higher proportion of white patients were prioritized over hospitals that take care of a higher proportion of Black and brown patients, even at a time when we know that there were huge racial disparities in how Black and brown communities were experiencing COVID in terms of cases and deaths and in terms of exposure to the pandemic. So with that, I'll stop the talk and open it up to questions.
Great talk. There's 2 questions in the chat from Dave Ennis. Why don't we start with those? The first one says, Black death rates are much higher than hospitalization rates among the comparison group. How much of this is explained by health disparities versus quality of care or access? So that's his first question. Yeah,
and I don't have an answer to that. I think that I don't think anybody has an answer to that question. I think it's a very important question. I think anytime we've looked at health disparities, I think people are quick to point out that it's a combination of the social determinants of health and then also inequities within the healthcare system. And those inequities within the healthcare system are complex. So it's not just what you have access to, but then, you know, what types of facilities you have access to, what types of providers you have access to, but then even once you get into the system, there can be differential treatment so that there is evidence that has been accumulating over, you know, at least the last 2 decades that show that at the individual provider level, that providers, there's, you know, differences in the way providers treat people by race and by income, but particularly by race.
And then I want to come back to that when I ask my own question, but first I'm going to ask Dave's second question, which is, do you have information on the pandemic era lobbying activities of the various hospital groups?
Yeah, so I have been looking into this a little bit, and the essential hospitals, which is the kind of the name for the association that if you're a safety net hospital, you join the Essential Hospitals Association. Now, the problem with even this term safety net in the US, as I'm sure David knows better than anybody, is that you know, you can be a pretty wealthy academic medical center that provides, you know, important services to Medicaid patients. You could be labeled as a dish provider, but also be doing quite well financially because you're able to, given your kind of reputation and your status in your particular market, you can command, and I'm saying you can because this isn't the case for all academic medical centers, but for a good many of them across the country, that they can command pretty high prices from private insurers. And so even though they are considered part of the safety net and they take care of Medicaid patients, they, many of them are very much in this group of looking really quite good financially. So, these definitions that we have to describe hospitals are pretty imperfect. So I just say that because when you look at lobbying, the American Hospital Association certainly lobbied for more provider payments. It definitely lobbied to base it on lost revenue. You know, it was concerned about lost revenues. Absolutely, it was. The Essential Hospital Association was much more concerned about COVID need and getting that separate distribution, that separate allocation to the hospitals. Another important lobbying entity that I didn't even talk about today, but I just kind of want to raise is that the financial industry, the private equity firms that have moved so heavily into the healthcare system have also been lobbying. It's hard to kind of find their lobbying because they have a number of kind of their black money, the dark, is sort of very, very hidden in terms of where the funding is coming from when they do political advertising and political campaigns. But they, when there was a rule that hospitals that received the relief funding, that they couldn't use that relief funding and at the same time do anything related to surprise billing or to try to go after COVID-19 patients if they were uninsured, or trying to go after them in terms of collections, for example. And the private equity firms that are in the surprise billing, they're very much in the surprise billing industry of making that they've been behind that whole surprise billing phenomenon, and have been very, very strong in lobbying Congress to not do anything regarding surprise billing. And they let that go through the provider relief funds. But all of the attention to surprise billing has been pushed off the table at the congressional level. So these two things, I think, they're related, and the private equity firms play a really important role in this whole sort of phenomenon of the bifurcation among hospitals, I think, in the US.
Chat's been filling up with questions. Jennifer Benny has a question. In this conversation, is there a difference between equal access and equity of access? And if so, what would you say the difference would be that's affecting patients?
Yeah, I think that's a really, really important point, that equal access, it's hard to even describe exactly what that would look like. We obviously, I think everybody knows we don't have equal access. If equal means everybody has the possibility to go to the same provider if they wanted to, the provider of choice, we absolutely don't have that. We don't have, the way we've set up our whole system is that people have very selective access to different types of providers. And if we're focusing again more on the hospital industry, we know that the type of insurance we have determines which network of hospitals we have access to. Then there's, as I think you're getting at, sort of once you get at it, it's not that the safety net doesn't provide good care. I think whenever you start talking about inequities in the safety net, I think some people that work within the safety net can become a little bit defensive because it implies that really poor quality care is being provided by the safety net. And that's not really my point. My point is more, if you are in much less financial health as an institution, there's only so much you can do in terms of having the same level of access to technology, or access to care, or access to a broader panel of providers. There's just only so much you can do relative to a hospital that has a lot more financial capacity. So even in terms of capital investments, I mean, the safety net is, if you have a low credit rating, it's really hard to get a loan. It's hard to have the same capital investment to improve your hospital system. And this has been true for a long time in the US. This isn't a new phenomenon. So it's kind of similar to what other people are saying about health disparities. These health disparities existed prior to the pandemic. And these inequities within our hospital system, within our healthcare system, existed prior to the pandemic. It's just that, again, the pandemic made them much more visible, I think. And then our response could have been different, but our response is actually quite similar to the way we have responded for a long time to differences within our healthcare system.
If I could cut in with my own comment, Caroline Kelly and I talked to stakeholders about some of the COVID disparities across hospitals, and I kind of expected to hear that the more resourced hospitals would have more ventilators, would have access to advanced therapeutics like remdesivir. And what we were told by the people in ICUs was actually they just had more bodies, and that the biggest thing when you have someone with acute respiratory distress syndrome is to be able to place them prone. But that's actually a very labor intensive and difficult activity. You need lots of nurses and physically strong people around to sort of help position the people. And that a place like the U of C, basically that the COVID patients had very similar issues to other ARDS patients, but a well-resourced hospital could provide sort of the basic blocking and tackling better. And it very often was very simple things, but things that are very difficult to do at the scale required because it's just super labor intensive.
Mm-hmm.
And that there were and that there was a significant difference in mortality rate that came from very simple things like that. That the less resourced hospitals just were hard pressed to to do during the crisis.
Right. Absolutely, that's a great point.
So, so I'll get to another question now. A question from Sadiq Patel. For those hospital systems that have transitioned to virtual care via telemedicine for non-emergency care, to what degree could the digital divide contribute to exacerbating disparities in access to care among low-income minority patients?
Oh, I think it's a big concern. I actually had another graph that I took out because I wanted to make sure there was enough time for questions. But one of them was the disparity, again, focused on racial disparity in terms of access to telehealth, or the ability to be able to do telehealth and to work remotely. So really, again, related to employment. And, again, sort of the graph looked similar where to the graphs we were looking at before, where whites have a much higher probability of having access to telehealth as Black and Brown patients. So I think it will exacerbate because I think many of us have heard about, there are many really, really positive things actually that I think we've learned about telehealth since the pandemic, that for some people that have a good connection and have a home situation where they can sit in a room, perhaps privately, so they can have a session if it's a mental health session, for example, or substance use disorder session. You need some privacy as well, right? So it's not only having a good connection, but also having a home situation where you have some privacy, or that you're able, that session is going to work well. And again, if you have more resources, you have more wealth, you're more likely, like I can close my door here in my office, right, and do this Zoom call, and that's not the case for everybody. So I'm really concerned that as hospitals and health systems realized, wow, telehealth is the wave of the future, it's much cheaper, we can reach people, this is going to work for everybody, that the people for which it doesn't work, again, are going to be left behind, and it's going to be the more, the less resourced institutions trying to do that care. So.
I'm going to march through. There's quite a few questions in the chat. Many of them, I'm afraid they say anonymous attendee, so I apologize for those of you who I'm not identifying. What is the justification for distributing funds prioritized on the basis of revenue lost over COVID need? Is it related to the difficulty of quantifying COVID need? Is this like Congress chose to lump sum increase in unemployment payments to distribute in a timely fashion?
I don't, that's a logical thing to think, but I don't think that was the reason for why why the first distribution was based on net patient revenues. I think the reason it was based on that is that a number of hospitals were reported to be hemorrhaging financially. The American Hospital Association did a report right away by, I think, March 20th. They had a report out, and that was that number was in my slide, which is that hospitals on average were losing $50 billion, obviously across a month in revenues, and that hospitals were on a financial downward trend. And because they're such an important part of the U.S. economy, that this was just going to have a huge economic impact on the hospital industry. And again, the writing was already on the wall, because there were a number of furloughs that happened already in March before the first distribution, and then again in April. So the first distribution was very clearly intentionally meant to help those hospitals that had the biggest financial losses because of its impact on the U.S. economy. And I think the hope was that hospitals would not furlough any more workers, that once they got these relief funds, that they would be able to do things so that it wouldn't have such a strong impact on the economy. I think there were a couple things, again, that were concerning that hopefully came out somewhat in my talk, but I want to just highlight again quickly. One is that there were a lot of, the way in which they came up with that distribution, a lot of hospitals that were not suffering so much financially. I mean, you can have a lot of revenue loss and still be profitable at the end of the year. And I think that's what we're realizing after the fact, is that a number of hospitals that reported revenue losses still at the end of this year, of this calendar year, will be coming out quite profitable. And a number of them, if you have a lot of cash cash on hand, that suggests in a market system that hospitals have been really arguing for the last 20 years that we should have a competitive market-based system. You might argue that, well, why should we help a hospital that is in a really good financial situation, and in fact help them more than a safety net hospital that is not in a good financial situation? So I think there are huge concerns about the fairness of this distribution, and on top of it, that it didn't help our economy. We didn't get the boom to our economy by helping these really affluent hospitals. The other finding that came out from the Becker Hospital Review is that those same hospitals that got the relief funds continued to furlough workers. So they didn't behave in the way that I think Congress was hoping.
Well, let me ask you a question that's a little bit discomforting. That, I mean, in general, I share the viewpoint of your analysis, but another thing that I heard when we talked to stakeholders had to do with some of the safety net hospitals who did not want to transfer patients to more proficient hospitals. And one of the things that we heard that was ironic was that a lot of the receiving elite hospitals did not want to take Medicaid patients who were COVID patients who required ICU care, whatever, but also that the hospitals that had them in their ICUs, where they were not really well equipped to take proper care of them, did not want to give them up. And there was a large difference in mortality rate, and both for reasons of economics, because some of these safety net hospitals, they really needed these patients to help cover the ICU, and also for organizational morale reasons and other reasons like that. And what do we do? I mean, it seems to me that one of the lessons of COVID is that there needs to be a higher degree of regionalization for certain types of care that were just done at a higher quality in a small number of high volume hospitals that were equipped to do it. And how do we, I mean, there is a reality that many of the safety net hospitals do not provide care as proficiently in certain situations as U of C, Rush, Northwestern, et cetera. And how would you deal with that issue?
Well, I think your comment, Harold, that maybe what we need to do is regionalized planning, right? And focus on hospitals that do well, have high volume, that certain procedures would be the kind of the hospital of choice, that in a planned system that we could do regionalization. Now, having said that, I've been writing this book that's covered a lot of this history of the U.S. hospital system and thinking about building the U.S. Healthcare infrastructure. And regionalization has been talked about for an unbelievably long time. And so they were the American Hospital Association, but more importantly, the Public Health Service was promoting regionalization in the post-war period in 1945 when we started the Hill-Burton distribution, which for those of you who are on the call who don't know about Hill-Burton, that was really what built our hospital system. Most significantly was starting in 1946 was federal government funding across the country to build community hospitals. And regionalization was behind that. The idea was that we would build it and there would be a plan, and ideally there would be coordination and regionalization. Now that didn't happen for a whole number of reasons. And we tried it again in 1965 with Medicare and Medicaid. There was a number of planning bills, a huge planning bill in 1974 to do regionalization again. And it didn't happen. And by the time we got to 1980, planning was considered a horrible failure in the US. Really what they called it was government regulation, but it was always voluntary planning. So in my view, the reason planning was a failure is because it was voluntary, and there were no incentives on the hospital industry side to voluntarily participate in planning. But it was deemed a failure because of government regulation. And then from 1980 until present, we have completely abandoned any notion of planning and regionalization and just gone towards complete competition. And I think, since 2000, with private equity and the financial markets moving into the system, we've had a major increase in mergers and acquisitions and huge monopolies now in the hospital industry, and very little evidence that there's really competition happening in the ways that we might hope it would work. And so I think today, hate to be such a downer here, but I think we don't have regionalized planning. We also don't have competition. We just have huge monopoly organizations in the healthcare system that can command really high prices, or the safety net that's hobbling along, trying to get more public funds. I should say now, those hospitals that are in a better financial position, it implies that they are not dependent on government subsidies. They receive an awful lot of government subsidies, and it explains a good reason for why they're in the financial position that they are. So it's not that they're off independent making all this money through just private innovation, it's government subsidies. So I think that's another important part that we need to really rethink in the US is we're funding the system we have now, and we can decide to use our funding to create a better system.
Okay, I'm going to march through these questions. So one says, very interesting analysis. Thank you for sharing. Do you plan to do this analysis on a national level eventually, or due to data limitations, only additional case studies of certain locations?
No, we're actively trying to get the full national database together. It's just unfortunately, this talk came before the data was ready. So that's where we're headed. We have the data available from HHS is for the entire US on all the payments, and then the RAND database has all the US as well. So it's just that merging. Anyway, it's just that distribution is, it's tedious. So we're getting there, but we unfortunately weren't there yet for today.
And, what action steps do you recommend for us listening to take to encourage health providers and administrators to hold them accountable to appropriately distribute funds to ensure that Black and Brown patients are properly cared for?
To me, what's really, really important is that I don't think we can hold hospital administrators accountable. And the reason I say that is because they are acting in exactly the way you would expect them to act given the healthcare system we've set up. And so we have to change. We need legislation. We need government reform in place to change the incentive structure and the behavior of the hospital industry and the broader healthcare system really in general. And I think part of it could start with the major role that the financial markets have in our healthcare system now is hugely concerning. They are completely unregulated on the private equity side. And they've had a huge impact on the healthcare system, and the government has done absolutely nothing. So I would love to say there's just things we can do. I think community benefits, that's been talked about a lot in the US on the nonprofit hospital side, that we can hold them accountable to do more on the community benefit side. And I think, I just feel like that we've been trying to get nonprofit hospitals to do more on community benefits for quite a while now. There was, new regulations under the ACA that really just reporting regulations. And it does look like for some nonprofit hospitals, there was a slight increase in community benefit spending, but not significant. And a lot of the nonprofit hospitals, especially those with more financial stability, tend to use, Medicaid lost reimbursement, they call it, which is basically just if they have higher Medicaid patients, they write that off as community benefit, which is not necessarily, it's not the community benefit that invests in a community in terms of social determinants of health. There's a very, very small number of hospitals across the country that are really making those investments. And again, it's because it's completely voluntary on their part. And the reporting allows them to write off things. Research is written off. Academic medical centers, a really high proportion of their community benefit is research. And not that research doesn't have a huge benefit to society, it does, but that's not the community benefit for Black and Brown communities that I think we're talking about here. So I don't put a whole lot of faith in this notion that if we rethink community benefits for nonprofit hospitals, we'll get a change. I think we need something much, much larger and significant than that.
So Rob Meeker had a question. With widespread discussion about the pandemic precipitating a mental health crisis, what is your sense of how PRF funds affected mental behavioral health care, at least as it's provided through hospital systems? Have fewer safety net hospital emergency rooms been able to treat people in distress?
So I should start by saying I don't really know the answer to that. I haven't looked at the funds going specifically to healthcare providers and systems that are really dealing with behavioral health issues that have really risen during the pandemic. Having said that, your question about sort of like safety net hospitals, I think given that they've had to deal with a much higher proportion of COVID need, and they've gotten relief payments, but they're much lower per bed than what affluent hospitals are getting. I think they're still in a position where they're not really able to give the financial attention they would need to really increase resources on the behavioral health side. So I don't see that we've had the influx of funding for that really is necessary to really be able to deal with the increasing need on the behavioral health side. I think, especially around substance use disorder, I mean, there's been such a huge increase in need. And I don't think the treatment facilities have really gotten a whole lot of these provider relief funds, but Harold also works in this area of the opiate epidemic. So I don't know, Harold, if you have any information on that that's more specific.
No, it's a hard one. I mean, I think there's been some innovation, and telehealth is has opened up opportunities for different modes of care. We do know there's been a real increase in opioid overdoses during the COVID crisis, and there's a number of reasons why that's true, and no one has a perfect handle on that, but one is that more people are home using drugs alone, and they're at higher risk of dying. There's also boredom and stress, and I'm sitting at home and all I have is my liquor cabinet and whatever's in my medicine chest, and I'm stressed out, and you can imagine. And there's fewer social controls over my use of substances at times when I might not have been using before. So there's a number of new challenges. I do think that people have become accustomed to telehealth in a way that may be very helpful. Prescribing authority is being loosened so that people who want to get medication, opioid use disorder treatment are going to be able to get it more easily without physically being present at a provider, and I think that will have some benefits. So there certainly are innovations, but we're going through a really challenging time. We have two pandemics going right now. One is COVID, and the other is opioids.
Yeah.
Gregory asked, will the election potentially change the funding amounts and activities in the future?
So I certainly think if Biden is elected, and very, very importantly, if the Senate, if the majority would change to Democrat, I think you can see just from the debates currently going on around a new stimulus package that we would be more likely to get a more generous stimulus package. On the provider relief funds, it's not, honestly, I really hate to say this because I do think that the Democratic platform is much more attuned to healthcare issues than the Republican platform. I did actually look at both platforms before this talk, and the Republican platform says nothing about health disparities, whereas the Democratic platform does, and has a plan for dealing with health disparities. Now, most of the plan is around affordability and focusing on the social determinants of health, which are really important things. But they don't mention the inequities within the healthcare system. And so there's nothing in the kind of Democratic platform. And again, this is just Biden, so he's an important. If he gets elected, that's very important. But we have the Congress that actually will pass the legislation and would pass what these relief funds would look like. But there was more push from Democrats in Congress when HHS was developing the formulas and distributing the funds. There were certainly a handful of Democrats that were really concerned that safety net hospitals, number one, were the last in line to get the distribution, and number two, that the first in line were the affluent, really kind of the most affluent hospitals got the most, and they didn't have, they could just look at the formula and kind of know that would be the likely end distribution, but also it was so hidden and not very transparent. So that's part of what the congressional members were fighting for, more transparency from HHS on the distribution of these funds. Again, having said all that, they didn't really talk significantly about, they would talk about the safety net, but not the reverse, that you have a lot of affluent hospitals that are getting too much. They kind of were very quiet on that. And I think it's because these health systems are major donors. I mean, they're major players in our economy. They're major players in almost every community. I mean, even Nancy Pelosi, who I think is, very supportive of the ACA, of healthcare reform, of doing something about health disparities, wanted private equity, wanted businesses that had private equity backing behind them to be funded, because private equity is such a major player in her district, in California. So it's complicated, and the lobbyists and the interest groups behind what keep the system in place are really entrenched. And that, to me, is the hardest nut to crack. It's like, how do we upend this given the significant interests that really want to keep it in place?
But isn't this a classic issue in the entire history of American health policy, that we would really like to believe? I mean, I think many of us would like to believe that insurance companies are the major obstacle to change. Say if you believe in a public option or single payer, that insurance companies are really the enemy. And a friend of mine once said that the insurance companies poll akin to like Bernie Madoff in terms of their public popularity. And it's all, Massachusetts General Hospital is infinitely more important as a political force than Aetna is. And you're talking about major institutions that not only have tremendous lobbying clout and financial influence, but they also have tremendous public esteem and legitimacy. And when they come to legislators and they say, we are really suffering from COVID, that is something that is taken very, very seriously. And it's something that we have not confronted as a society, that it is, the entire supply side of the medical economy gets to charge high prices and resists efforts to at cost containment, at some of the equity issues that you're talking about. And COVID brings it into sharp relief, but it's not super different from many other issues that have come up.
No, you're exactly right. Absolutely. I mean, I think the only, again, I'm kind of trying to drive this home, which is that I think the supply side of the healthcare industry has always been very, very powerful. Different actors within that system have changed over time, and so some are more powerful at certain times than others. What I think is quite different today is the role of capital markets. Wasn't always there to the degree that it is today. So, I mean, the capital markets really started moving into healthcare starting in 1965, but really shot up quite significantly in the post-1980 period, and then with private equity firms starting in 2000. And there, what's a little bit more complex about their role is that it's very hidden. And so we can see, oh, it's Mass General, or it's, it's Mayo Clinic, and it's revered and has a good reputation, but we don't know these financial investment firms behind all these entities and the role that they're playing to really shake up the system. And it's not only hidden, but they're giving a lot of money that's also hidden. And that, I think, kind of changes the dynamic of the political dynamics in ways I don't think we fully understand quite yet.
I think your point's well taken, but I do wonder if we look at, say, the disparities in the quality of breast cancer care between the University of Chicago Cancer Center and Stroger, or in Provident, we would also find, very significant differences and very significant disparities in resources. And, there are, private equity is certainly has been a bad actor in specific instances that you can point to, but it's, but there's plenty of other stuff going on that is, that we have to somehow address.
Oh, absolutely. Absolutely. And I'm not, I wasn't disagreeing with you. I was just kind of adding on that there's this other layer that even complicates what's been around for a while, which is, just as you said, the hospital industry. There's significant interest. And it's not that they do a lot of good, right? Which is part of what makes it very, very difficult politically to think about, rearranging the system, right? Is that not, there are lots of interests that don't want to change what our most prestigious health systems that also make a lot of money, what they do, right? So it's complicated.
So two last questions. One is from Brendan Hill. The CARES Act also provided payroll protection, the PPP, and a $200 million distribution to the FCC for telehealth funding to hospitals. Do you have a sense of if differences observed by hospital type may be offset by these programs at all, or are the more affluent hospitals more likely to get federal assistance sort of all around?
My impression, but I need to look into the PPP funds more specifically, because I've really been focusing on the provider relief funds, but that the systems that have more capacity to apply for those funds and be on top of it were more likely to get the funding and to get more of the funding. So I think that the story will likely be exactly what you stated in your question, that the affluent hospitals are going to benefit all the way around because they have the capacity to kind of go after those funds in a way that is a little bit more difficult for some of the safety net hospitals. But I can't, that's what I think is happening, but I don't have the data right now to back that up.
Oh, one thing, since we're getting to the end, what is a question that I should have asked you that I didn't ask you that came to mind as you were listening to the questions? Is there anything anything that comes to mind?
Oh, well, if I was a good presenter, I would have saved my private equity spiel until this time instead of like hitting people over the head with it. But yeah, that was the main thing I kind of want to try to get across to people is the role of the financial markets in the healthcare industry, I think are just really important. And I don't think we quite have a very good understanding of what that role is. There's very few studies out there that actually, they're just coming out. There's a few in JAMA now that look at the presence of private equity and differences in outcomes. But we really don't, we know they're playing a major role, but we understand very little about what that is. So I think that adds to and my concern is that I think it's making a bifurcated system even more bifurcated and unequal. And so I think it's important for us to be thinking about what that role is.
Then one final question that which is a little bit inchoate, but one of the questions that I've often thought about is the role within organizations and in politics of Medicaid's low reimbursement rate is not only creating concrete incentives not to treat poor people, but also as a way of framing issues in a way that is particularly toxic to dealing with these equity issues. That when I talk to people in elite hospitals, why aren't you nicer to poor people? One of the most common things that I hear, certainly in Illinois, is here's Medicaid's reimbursement rate, and here's how late Medicaid is in paying what they owe us. And that becomes a part of the organizational conversation in a very pronounced way. And I just wonder if that needs to be part of the conversation too, not only in the direct way that it creates concrete incentives, but also the way that it changes the whole cultural vibe around safety net care.
Yeah, no, I that's a really, really good, important point. I do think that the public option, and that's under Biden's plan, he's promoting a public option. It's a Medicaid public option. I'm not sure everybody understands that. So under Obama, when we passed the ACA, a number of Democrats were fighting for a public option, but that was a Medicare public option, which meant Medicare would be on the marketplace just with the private insurance plans as another option that people could choose from. They could choose to join Medicare or, Aetna's private plan. In this case, it will be a Medicaid private option, and it will be offered at the state level. So if a state wants to provide a Medicaid public option, it can do that. And that's kind of interesting. I mean, it has, so I think the reason people favor Medicare, right, as a public option is that you could, if you got more and more uninsured people on Medicare, Medicare has higher rates, and that would provide more access to a broader, a much broader panel or network of providers, right, because they're paying the Medicare rates. What I think, though, could happen under a Medicaid private option is that if you just get a lot more people in the state on the equivalent of Medicaid, and those people vote and they have power, they could, that could try to turn into pressure for higher rates, right? Pressure because they say, listen, we need more, we want better access to a broader network of providers, a broader network of hospitals. There shouldn't be lower class care. And the reason it's been lower class care forever is because it's been publicly stigmatized, and state governments perpetuate that by paying lower rates, right? That then affluent hospitals can say, well, we don't want to take lots of those Medicaid patients because of the lower rates. They don't have to say it's because they're poor and they're Black and brown. It's because they pay lower rates. And if you brought the rates up, then, you know, you'd say, well, there's no other, you know, you could bring the rates up and then require that everybody has to take care of them. You know, I mean, that's part of moving towards getting rid of the safety net is through the payment system. So I think you're exactly right, Harold, that has to change, because as long as we have these different low Medicaid rates and different ways in which Medicaid pays, it's always the affluent can deny access. The affluent hospitals can deny access, or the affluent providers. And we've set up the system in that way. And so if we do a public option with Medicaid, it could still create change. I think it's important to think about that, but there has to be regulations that go along with that, I think, to help bring that change about.
That's
so
a great,
there may be hope.
It's great to end on a note of hope. Great
Yes.
questions, everybody. Thank you so much for attending. I should say that next week we have an SSA alum speaking from the University of South Carolina, Christina Andrews. So, so thank you, Colleen. This was terrific. We'll give you a. I'm looking for my little applause thing, and I'm not seeing it in the Zoom menu.
Well, I'll give you applause as well, Harold. Thanks for great questions, everybody. Thanks so much for spending the time to be on Zoom. To listen.
And did Faye Lomax cook? Did you want to? Did she raise her hand just now?
She did. Let me.
I'm sorry.
I'm bringing her into the conversation now to hopefully.
I'm sorry, Faye. Apologies. And she asked a question early on that was asking about policy implications, which I think might have been superseded. But Faye, did you want to comment?
Her microphone is muted and her.
Oh,
here she is.
It was a fabulous talk, Colleen. I really enjoyed it. I sent a question. We can talk later. It was wonderful, wonderful talk. It was just great. I enjoyed it.
Oh, thanks, Faye. So I can't see your face, but I can see your name and hear your voice, and that's wonderful. Thanks so much for listening, and I'd love to talk to you more about it.
And Faye, I'm sorry if I turfed your question incorrectly. I apologize. But thank you, Colleen, and thank you everyone for coming. And what a great way to kick off the year.
We'll see everyone next week. Thank you.
Take care.